Now, my dear friends, in this segment, let us talk about the blood supply of nose and epistaxis, which is a very common clinical entity asked in exam also. First of all, anatomy. The nose has got a very unique blood supply because nose gets the blood supply from two systems, external carotid artery and internal carotid artery. Let us understand which area is supplied by which particular system. The level of demarcation between the ECA territory and the ICA territory is the middle turbinate. Okay, so up to middle turbinate is ECA blood supply source, and the above middle turbinate brain side is the ICA blood supply coming over there. Let us see over here. This is the level of demarcation of the ECA and ICA territory. Okay, below this is the external carotid artery, and above this the circulation comes from the internal carotid artery. My dear friend, ECA provides 80% of blood supply to the nose and ICA gives 20% blood supply to the nose. So, above the middle turbinate, the brain side, the blood supply comes from the ICA, but that's a 20% of total circulation. Now, let us guess the name of the blood vessels. From ECA, 3 branches go to the nose, and from ICA, 2 branches come to the nose. Okay? Let us guess the name of 3 branches of the ECA territory. Now, please see what lies below the nose. Upper lip, hard palate, soft palate. Below the nose is upper lip, hard palate, soft palate. Let's guess the name of artery. Upper lip, superior labial artery. Upper lip, superior labial artery. Now, hard palate, greater palatine artery. Then lastly, soft palate, SP. Soft palate is sphenopalatine artery. So once again, lip, palate. So superior labial artery, greater palatine artery and sphenopalatine artery, they are going from below upwards. Now, let us guess the 2 branches coming from ICA circulation. Anybody, which bone is between 2 orbits? Yes, ethmoid bone. So, name of artery will be anterior ethmoidal artery and posterior ethmoidal artery. Okay, it's easy. So, let us see the ECA circulation, which is 80% of total circulation. From ECA come 2 branches, maxillary artery and facial artery. From maxillary come 2 branches, sphenopalatine artery and greater palatine artery. And from facial come superior labial artery. Okay. From ECA, 2 arteries, maxillary and facial. From maxillary, 2 branches, sphenopalatine and greater palatine. And from facial, superior labial artery. Let us see ICA, above middle turbinate, to 20% of total circulation ICA. ICA give 1 artery, ophthalmic artery. Now, ophthalmic artery give 2 branches for the nose, anterior ethmoidal artery and posterior ethmoidal artery. But my dear friend, it's only 20% total circulation and the territory is above middle turbinate. Look at this table. So, 80% blood supply up to middle turbinate comes via ECA. Okay. And from ECA, 2 branches, maxillary and facial. And from maxillary come 2 branches. Number 1 is sphenopalatine, number 2 greater palatine, and from facial, superior labial artery. Let's go to the ICA. Above middle turbinate, it belongs to the area of ICA territory, and this is only 20% of total circulation. From ICA comes which artery? Ophthalmic artery. And from ophthalmic artery, 2 branches which are coming are anterior ethmoidal and posterior ethmoidal artery. So there are 5 arteries supplying the nose, but 80% is from ECA. Now, one question. Which artery is called artery of epistaxis? Answer is sphenopalatine artery. In majority of problems, when the bleeding is not able to be controlled by usual maneuvers, generally one of the branches of sphenopalatine arteries is the bleeding. So, the artery of epistaxis is sphenopalatine artery. Now, let us start epistaxis, a very common occurrence, particularly in school life. You must have seen a lot of your friends or classmates having bleeding from the nose. Let's talk about it. Now, what is the most common area of epistaxis? The answer is Little's area. Anatomy. Little area lies on the antero-inferior part of septum. It's on the septum. On which part? On the frontmost part and the lowermost part. Over here only, right? When you put finger in the nose, you touch the septum. Which area you're touching? Little area. So, little area is a highly vascular area lying on the antero-inferior part of septum. Now, what does little area contain which bleeds so much? Little area has Kiesselbach plexus made by 4 arteries. We have total 5 arteries, but Kiesselbach plexus is made by 4 arteries. Which arteries contribute to the Kiesselbach plexus? Let us see, out of 5, 4 arteries contribute to Kiesselbach plexus of little area. So, Nemo area is little area and Nemo plexus in that area is Kiesselbach plexus. It is made by 4 arteries. Number 1, Greater Palatine. Number 2, Sphenopalatine. Number 3, Superior Labial. And number 4, Anterior Ethmoidal artery. My dear friend, famous question is, posterior ethmoidal artery has no role in the contribution to design of Kiesselbach plexus. So, which artery has no contribution to Kiesselbach plexus? Answer is posterior ethmoidal artery. Another plexus people think that this is also contributing to some cases of epistaxis is Woodruff plexus. Now, my dear friend, where is Woodruff? This is Woodruff plexus. The picture is of the lateral wall of nose and you're seeing it on the lateral wall of the nose, not on the septum. And my dear friend, this is a venous plexus. It's a venous plexus, not arterial. It's a venous plexus and it is a posterior plexus, not anterior. Okay, so it's the posterior part of the lateral wall of the nose. Okay, so Woodruff plexus is not a very common site of bleeding. It is uncommon site of bleeding, but you should know how to differentiate Kiesselbach from Woodruff. First of all, Kiesselbach is arterial plexus and the Woodruff is venous. Okay. Number 2, Kiesselbach is in the anterior part of the nose and Woodruff is in the posterior part of the nasal cavity. Okay. Third is Kiesselbach is on the septum, on the antero-inferior part of the septum, and the Woodruff plexus is on the lateral wall of nose, just above the inferior turbinate. Just above the inferior turbinate is the Woodruff plexus. Let's revise once again. The Kiesselbach plexus is arterial, Woodruff is venous. Kiesselbach plexus is in the antero-inferior part of nasal septum, but Woodruff plexus is on the posterior most part of the lateral wall of nose, just above the inferior turbinate. Kiesselbach is the commonest site of bleeding and Woodruff is uncommon site of bleeding. Let us talk about the causes of epistaxis. Number 1, most common cause of epistaxis. You know it already. It is fingernail trauma. Why? Epistaxis is mostly seen in school children. You must be remembering, fingernail trauma or nose picking habit. Nose picking habit. The commonest cause of epistaxis is fingernail trauma or the nose picking habit. My dear friends, imagine the school time, some kids are busy in the own, teacher is teaching on the board something, whatever teacher is writing on the board, it is a private matter between the board and the teacher only. Some kids are busy rotating finger in the nose like that. Guys, little area is in the antero-inferior part of septum. It is too anterior, too inferior, and that's why it's available for your nails also. One fine day, the student erodes the mucosa of the little area and start bleeding like this. Then teacher says, hey, press the nose. Pressing the nose tip is scientific. Why? Pressing nose tip means you're pressing little area and the clot formation happen over there and bleeding stop. After a few days, somebody scolds the child. Child is crying and while crying, they're doing like this. And they displace the clot and bleeding start and now it's a recurrent affair over there. So commonest cause of bleeding is fingernail trauma or nose picking habit. What about young adults? In young adults, the cause of bleeding from nose will be trauma. Some accident, some fall, etc. And in traumatic bleed in young adult, the source of bleeding is what? The source of bleeding is retrocolumellar vein. There's a vein in the columellar area, retrocolumellar vein. That's the commonest site of bleeding in traumatic cases in young adults. Now, let us talk about elderly people. In elderly people, it can be because of atherosclerosis of the blood vessels. Atherosclerosis of the blood vessels of the nasal circulation. That is one cause. Number 2, hypertension also. My dear friends, hypertension causes posterior epistaxis. Posterior epistaxis. Now, what do you mean posterior? My dear friends, this is anterior epistaxis when the blood is flowing from the front end of the nose, which is a usual case actually. But what if the bleeding start from the posterior part of nose and the blood start falling in your throat? This type of bleeding is called the posterior epistaxis. And in elderly population, we see due to hypertension or atherosclerosis, the bleeding is posterior. Okay, so majority bleeds are anterior, but hypertensive or atherosclerotic bleed in elderly population is posterior epistaxis. So, in hypertension, because we see the posterior epistaxis, it is generally severe and difficult to control. And it would need packing in the nose to put the pressure on the bleeding area. And of course, you need to hospitalize the patient also. So let's revise. Hypertensive bleeds in elderly population or atherosclerotic bleed in elderly population, they are posterior, severe, difficult to control, generally need packing and hospitalization. Now let us think about some systemic conditions which can lead to epistaxis. Think like a doctor. Can you think of any? Number one will be what? Bleeding disorders. Bleeding disorders. You must have heard the name hemophilia, von Willebrand factor deficiency. Have you heard these names? The coagulation disorders. Guys, when you hear the word von Willebrand factor deficiency, you think that it's a very hi-fi disease occurring in the Europe, Australia, New Zealand, America. Not at all. The names are European or maybe English names, but diseases are Indian. We are 140 million people. Every sixth human on the planet is Indian right now. These occur in us, not in New Zealand. New Zealand, what, 55, 60 lakh people. 55, 60 lakh people is nothing. These many people go to, Tirumala or Kum or any other shrine in 1 week only in India. So we are a country of 140 million. So don't expect that rare things are not occurring. If rare things are not occurring in India, they won't occur anywhere else also. Okay? So don't go the fancy names. They won't occur in Canada. Canada is how much? Like maybe 3.4 crore population. That's all. Only Uttar Pradesh has got 7 Canada into it. Only Uttar Pradesh has got 7 Canada into it only. So don't go on the fancy names. Okay, fine. So all these disorder you see in the quaternary kind of institutes, definitely over there. These names are European because Indians never wrote medical literature. Please understand. Have you ever heard the name Gupta-ji syndrome, Sharma-ji sign, Reddy syndrome, or anything? Not like that, because we never wrote literature. Okay, so that's why it's very tough to remember the syndrome names and all that. It's okay, but we have to remember. Okay, so bleeding disorder. Number 2, patient taking anticoagulant drugs. Like a lot of people are taking aspirin nowadays, warfarin, heparin, or clopidogrel. Okay, a lot of people are taking anticoagulant drugs for some other reason, and they can also have epistaxis because of deranged coagulation profile. Hemorrhagic fever like dengue, dengue leading to thrombocytopenia, that can also. So think about systemic conditions which can be linked with the epistaxis. They can mix and match and make a question. Let us talk about the management. Number 1, first aid, the school time. First aid is what? Pinch the nose for 3 to 5 minutes. Pinching nose means pinching which area? Little area to support coagulation. Now, Trotter's method is a question. Trotter method means let it bleed. Sit comfortably and lean forward. Breathe through the mouth comfortably and let the blood fall in a kidney tray. And if the blood goes to your throat, don't swallow it. Just spit it out in the kidney tray. Okay? So sit leaning forward, spit the blood if it comes in the throat and breathe through the mouth comfortably. Okay? Now, this is mostly first aid. Now, if bleeding could not be controlled, then what? Then you take the patient to the emergency. Then there is CMO or intern. What you do is you take a cotton pledget and you soak it in xylometazoline or oxymetazoline or diluted epinephrine, and it's a decongestant, and you put that cotton pledget in the nose, which from the side it's bleeding. Okay, so these are just the basic things with it. Now, even if this could not control, then you call the ENT people. Okay. Now, ENT people will do what? Chemical cauterization of little area. Chemical cauterization, let's burn the blood vessel which is bleeding. Now, which agent we mostly use for chemical cauterization of little area? The answer is silver nitrate. Silver nitrate. AgNO3, silver nitrate. Okay, if that's not available, we can use the carbolic acid also. Diluted carbolic acid can be used. Okay, but this is preferable. Silver nitrate is the agent used for chemical cauterization of little area. If this also fails, then what? Then we do the anterior nasal packing. Look at this picture. This is the anterior nasal packing on both sides. On both sides to give pressure on the septum from both sides. Okay. How we do that? We take the tape gauze and we smear it with the liquid paraffin to make it, like lubricate it. Then you pack the nose layer wise layer. See this video. With the help of Thudicum antenasal speculum, we open up the antenasal cavity and we insert the pack towards the posterior part of nasal cavity, reaching up to almost choana. We must press this pack to make space for the further layers. The nasal packing should always be done layer-wise. So you just saw that the anterior nasal packing. Now, anterior nasal packing is a gauze-based packing. But nowadays, we are getting special kind of packs also. They are ready-made anterior nasal packs. They are made of PVA. What is PVA? Polyvinyl acetate. PVA. Polyvinyl acetate packs. Okay. These are traditionally called Marocil nasal packs. You should be knowing it because a lot of people are using this one. You just put this pack in the nose of the patient. This is the actual size of the pack. Then on that you put some normal saline. You spray normal saline on this pack. The moment it absorbs the normal saline, it gets swollen this way. Okay. Once it is swollen, it's going to put a lot of pressure on the nasal mucosa. Put one pack this side, one pack this side, and you then put the normal saline on these both packs and they are swollen to put pressure from both sides on the septum. Okay. These threads are to make sure that pack is inside, and later on you want to remove the pack, hold the thread and pull the pack gently out. It's pretty atraumatic kind of pack. PVA, polyvinyl acetate packs, are alternative to the gauze packs. So now anterior nasal packing can be done with two techniques. Number one, the conventional technique is the gauze-based packs, and number two is the PVA packs, polyvinyl acetate packs. My dear friends, anterior nasal pack, when you put it, it does not reach up to choana area. My dear friend, what is choana? Choana is the posterior opening nasal cavity. By chance bleeding occurring from that area, then the bleeding will still continue. You see, bleeding will still continue. The bleeding will not stop. Okay. Then you need to put one more pack over here, and that pack will be called posterior nasal pack. If anterior nasal packing failed to control bleeding, then you put one more pack, which is called posterior nasal pack. My dear friend, posterior nasal pack is always done in the operation theatre under general anesthesia. It's not a very easy pack to put because you're putting a pack through the mouth and right behind the nose. And it's always placed in conjunction with the anterior pack. So you're putting the anterior pack also plus posterior pack also to give pressure in all the area of the nasal cavity. My dear friend, this is the anterior nasal pack number 1 and this is the posterior nasal pack number 2. Okay. So this pack is always put in conjunction with the anterior pack. So this anterior pack and of course this is the posterior pack. This is the posterior pack. Okay. So let's revise. Posterior nasal packing is a major procedure done in the operation theatre under general anesthesia and it's always done in conjunction with the anterior nasal packing. Okay. So these two threads are to stabilize the pack in the nose, and the third thread is for removal of the pack after few hours. Because you want to remove the pack, third thread is hanging in the throat and you hold this thread and pull it back through the mouth and throw in the dustbin. So why there are 3 threads of the posterior nasal pack? 2 threads are tied at the nostril to stabilize the pack. Third thread, number 3 thread, hangs in the throat. It is for the later on removal of the pack. My dear friends, please keep in mind as an intern or post-intern also, that all packing should be removed from the body in 48 hours. 48 hours. The packing should not be kept for more than 48 hours, and whichever pack it may be the orthopedic pack, the surgery packs, the ENT packs, whichever pack is in the body should be removed within 48 hours. If you do not remove this pack, patient did not come to the OPD for pack removal, patient forgot or you forgot to inform the patient, then it can lead to death of the patient. Why? It can lead to toxic shock syndrome. You must have heard this word in microbiology classes. Toxic shock syndrome is septicemic shock and due to colonization of Staph aureus. Staph aureus, and this is very important question. All packs from the body should be removed in 48 hours. If you leave the pack for a longer duration, there's a chance of toxic shock syndrome due to Staph aureus colonization. My dear friends, by chance you did the anterior packing also and posterior packing also, but this packing fails to control bleeding. Then we have to now upscale the treatment. Okay. Now, how we upscale the treatment? We have to plan a surgery to control the bleeding. Surgery to be done to control the bleeding. I have a question to all of you. Which artery is called artery of epistaxis? Sphenopalatine artery. Very good. So the artery of epistaxis, sphenopalatine artery. We need to ligate this artery. And what is the name of this surgery? The name of surgery is TESPAL. Very important question. If anterior and posterior nasal packing fail to control bleeding, then which surgery to be done is TESPAL. What is TESPAL full form? Transnasal endoscopic sphenopalatine artery ligation. Transnasal endoscopic sphenopalatine artery ligation. The future question: where to give incision to find the sphenopalatine artery? My dear friends, sphenopalatine artery comes out of sphenopalatine foramen right at the posterior most end of the nose. But how to locate this blood vessel? First of all, we have to give a cut on the lateral wall of the nose. Okay, incision on the lateral wall of the nose. Okay, you can see this black line. This is the incision. Now, my dear friend, let me orient you. First of all, this is the lateral wall of nose, and this one is the posterior end of the inferior turbinate, and this is the posterior most end of the middle turbinate. Just 1 centimeter anterior to the posterior end of inferior turbinate, you give an incision and you lift the mucosa, and there you find the sphenopalatine foramen, and you see one artery coming out of that. That is the main trunk of sphenopalatine artery. So where you give incision for SPL ligation, 1 centimeter proximal to the posterior most end of the middle turbinate. Future question. Now the next one. By chance this surgery you did, TESPAL surgery done, you have ligated the sphenopalatine artery properly. My dear friends, if bleeding could not be controlled with sphenopalatine artery ligation, then it's a big problem now. This is typically seen in trauma cases. In this case, we have to do external carotid artery ligation, ECL ligation. To save the patient, it's generally a roadside accident case, major fracture of the head and neck area, the skeleton of the face is fractured, too much bleeding from the nose and mouth. You try to save the patient and you open up the neck of the patient quickly and you expose the common carotid artery, and from common carotid artery, we have two branches coming, ECA and ICA. ECA and ICA. Okay, fine. My dear friend, you, by mistake, if you tie the ICA, patient will die immediately and you will go to jail. So the neck is open, common carotid artery is exposed. I remember my first year PG, one of my senior consultant did this procedure at night. He opened up the neck of the patient, trauma case, lot of bleeding everywhere, and he exposed the common carotid artery, and there were two branches, and he called me, Rajiv, come here, tell me which is ECA and which is ICA. I was looking like that, and I want to tell him, please save the patient first. Then ask me question. By the way, I did not know the answer in that time. Anatomy will keep telling you, anterior, medial, posterior, lateral. There's nothing like that. There's nothing like that, honestly. When the neck is open, the surgical anatomy is different actually. When neck is open, both artery are like this, anterior, like moving like this. Which is lateral, which is medial. Don't trust medial lateral. This is a very crucial question. By mistake, you tie the ICA, patient will die immediately. So he said, Rajiv, don't tell medial lateral. The basic thing is ECA has got many branches in the neck, and ICA has no branch in neck. ICA is meant for brain and eye. It will only branch when it enters the cranial cavity. Okay. So one question of anatomy also. Which of the following is branch of ICA in the neck? Answer was none of the above. ICA has no branch in the neck. That's the only reliable point to differentiate ECA from ICA. Okay. Now, next question. If ECA ligation also fails to control bleeding, you tried the ECA ligation also, but still bleeding is going on, then what to do? My dear friends, answer is there in your mind. Let me help you. Please see on the screen. The ECA give 80% circulation, agreed. That you have ligated, but still bleeding is continuing, then it must be some branch of ICA which is bleeding. And what is the name of the branches of ICA? Anterior ethmoidal artery and posterior ethmoidal artery. So if ICA ligation failed to control bleeding, then the next management will be the ethmoidal artery ligation. Anterior also, posterior also. All these things are done on one side only. Don't worry. The other side, collateral circulation will be supplying this area also. Don't worry about that. Okay. So if ECA ligation failed to control bleeding, then the next management is again a surgery, the ethmoidal artery ligation. Ethmoidal artery ligation. Anterior, posterior, both. Don't worry, all these ligations are done only one side. Other side circulation will supply this side also. Don't worry about that. So if ECA ligation failed to control bleeding, the next management is ethmoidal artery ligation, because this is the coming from the ICA territory, and that is giving 20% of circulation to the upper part of the nose. Now, my dear friends, let's discuss one more clinical scenario. There's a patient of uncontrollable epistaxis, too much bleeding from trauma and all going on. Generally, we are not able to find out the site of bleeding because too much torrential bleeding is there. So we can't pinpoint, oh, that is the source of the site of bleeding. But if you're lucky, you did a nasal endoscopy to find out what is the site of bleeding in this patient. Okay, and you are lucky, and you could really easily see that the site of bleeding or the source of bleeding is from an area above middle turbinate. The area is above the middle turbinate, which is the site of bleeding. Then you tell me, which artery shall I be ligating? Greater palatine, sphenopalatine, superior labial, or ethmoidal artery? The answer is what? Ethmoidal artery ligation. Please see over here in the screen. Please see the area above middle turbinate. Area above middle turbinate is IC territory, and the name of blood vessel is anterior ethmoidal and posterior ethmoidal artery. So, if source of bleeding is by chance located to be an area above middle turbinate, then let us go for straight away ethmoidal artery ligation. And anybody, I have a question to all of you. If by chance ethmoidal artery ligation also done, ECA ligation also done, still the bleeding did not get controlled, then what? Then what? Let the patient die and go to the God? No, 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 no. Then refer the patient to a better doctor. You never thought about the cause of epistaxis. You kept managing epistaxis, but epistaxis has got an underlying cause. Patient was suffering from von Willebrand factor deficiency. You never thought about that. You kept tying on one artery, second artery, third artery after that. So whenever you manage epistaxis, uncontrollable bleeding, please think about rare hematological disorder of coagulation pathways.